Hello friends, welcome to StudyIQ. Through this video, we are going to analyze the basic features, the salient features of National Health Policy 2017. This policy was approved by the Cabinet in the second week of March 2017. So let us first see what are the salient provisions of the Constitution under which this policy has been enacted. The Constitution provisions under which this policy is given are: Number 1, as a subject, this policy, this health of citizens of our country needs to be taken care under which list? It is the state list of the Constitution that mandates the state government to take care of the health of the citizens. So as a subject, health as a subject is mentioned in the state list of our Constitution. Those who are aware, they must be knowing that state as a subject lies in list 2 of our Constitution. This is list 2 of our Constitution, given in Schedule 7, which is further given in Article 249 of our Constitution. So we have to realize this thing, that health as a subject lies in the state list of our Constitution. Now, when the health is lying in the state list, one logical question must be arriving in our mind, that how come this national health policy being approved by the parliament? How come national government is approving, that is central government is approving the policy? So the thing is, central government under our Constitution is mandated to ensure the uniform standards of health across the length and the breadth of the country. When we say length and the breadth, it is like Kashmir to Kanyakumari. So this is the thing, from Kashmir to Kanyakumari, our central government has to ensure the similar standards of health across the country. Now, when it is mandated to do so, central government, by enacting this policy, is not encroaching upon the legitimate constitutional area of the state governments. It is just outlining the broad contours. This is a policy which can be given shape by the states according to their own desires. It is not that state governments are mandated as they were under centrally sponsored schemes. So this is just that broad contours of the policy have been outlined, and the real shape could be given to them by the state governments also. So another thing is health as an area. It has happened that we had a policy in the year 2002 as well. This policy we will talk about. Now there is another question. We had a policy in 1983 as well. These policies could not achieve the desired objectives up to the level expected of these policies. So what is the constraint that we are unable to achieve the objectives of the policy enshrined in the policy in the year 2002? So if this question is put to you in the mains, the reason could be that center is like hand-bound over here. Center has limited avenues. Center can only dictate the normal policy contours, and it is the state governments that have to implement the policy at the ground level. Now, what if the state governments don't do anything? It was in the past that central government, that UPA government had created centrally sponsored schemes which were implemented at the state level, and these schemes were on the state subjects. So this was considered to be the encroachment on the legitimate area of the state's domain. So these schemes were abolished by the new government, that is the incumbent NDA government. So now these from 137 to just 66 schemes are left, centrally sponsored schemes, which are operating in different areas. Some of the schemes are working in health sector as well. But we are talking about health policy in entirety. So my answer to this problem is, when the center is like hand bound, what avenues does the center have? Is it the right juncture to talk about exploring the avenues? What can we do? If we were to explore the avenues of better implementation of a health policy, what are the avenues available? One, of course, is the centrally sponsored schemes. Second could be, and a more drastic could be, transfer of health as a subject. Many editorial writers, they say health as a subject could itself be transferred to the concurrent list. So thereby the center's domain would be increased to interfere or to legitimately intervene in the state's implementation of the health targets. So because the thing is, after 70 years of the independence, our health sector, health condition of our citizens is pathetic. Like today the report has come, the Human Development Report 2016. Under that as well, health indices measured in terms of life expectancy, they are shown to be in the poor light. So that is the reason that we need to explore these avenues, that after 70 years when we are unable to do this, it is the right time to even debate about the transfer of the subject of health from the state list to the concurrent list, so that center can legitimately then create schemes and create policies in the health sector. So this is one thing I need you to debate over. I need to formulate an idea or opinion over, so as to be helpful in your mains examination. Second thing is, this health as a subject is given in the directive principles of state policy under Article 47. Now the task for you for prelims is to go back to your polity books and read this article thoroughly, and please find out the other articles that deal with health as a subject. So this is one specific article I am talking about. There are other articles generally termed which also deal with the health as a subject. So you need to find out, and at the outset let us first discuss, this is the directive principle of state policy. Is there any article under fundamental rights which talks about the health of the citizens? Can we trace any article? It is Article 21, right to life, that a citizen can seek better health facilities from the state, especially when the 70 years have already gone by. These points that we are discussing could be applied in your essay paper, or could be applied in the mains GS paper 3 or GS paper 2, as the case may be. So let us proceed a little faster and move on to this thing. Background, why we need a health policy, in the new health policy in the first place. Let us analyze this as well. The last health policy of 2002. So the last health policy of 2002 delineated the concerns in the health sector at that point of time. So it highlighted the concerns of the 2000s, the era of 2000. The decade of 2000, we can say. So this was the concern, the national concerns as well as the international concerns. We will talk in these two broad ways. One is national and international. When we talk of national concerns, the concerns of that era was diseases like polio and other such diseases. Now that WHO has labeled India as a polio free country, so this is our priorities have changed. So hence a new policy is required, and when we are talking of national thing. So this policy was 2002 policy was enacted in the backdrop of Millennium Development Goals. This was to give shape to achieve the Millennium Development Goals in terms of maternal mortality rate, in terms of infant mortality rate. So that was the idea. Now since the Millennium Development Goals have been achieved, or their term is over by 2015, hence the new policy to fulfill the India's new international commitments in terms of sustainable development goals. So now we are talking about sustainable development goals. So this you have to bear in mind, that last health policy catered to the challenges facing the Indian health scenario of that time, of that era. Now the new health priorities have emerged, and hence the new policy is required. Let us see the second point. India still carries 1/5 of the world's disease burden. So this is the thing. Even though 2002 policy have led us in good stead, but still a lot of ground still remains to be conquered, in the sense that we are still the country which carries the 20% of the burden of the world disease burden. So that is the thing. We are having 17% of the world population and carrying the 20% of the health burden, disease burden. So that is the thing, that we still need to cover a lot of ground. This is another reason. Third reason is growing incidence of non-communicable diseases. This is a very important reason, that now we have transitioned as an economy from agriculture, primary sector led economy, to service sector led economy. The world history in terms of this thing says that when an economy transitions from agricultural led economy to primary sector led economy to service sector industry led economy, what happens is the disease pattern or the lifestyle pattern of the society changes, and accordingly the disease pattern also follows with it. That is, then we had communicable diseases. India being a tropical country, we had communicable diseases. These are still prevalent, but new kind of diseases which are non-communicable diseases like obesity, like diabetes. So these kind of challenges are emerging now. So we need to have a new policy to cater to such challenges. So that is another need for new policy. And this fourth point is in tune with current epidemiological realities. So this is the points are basically related with each other. Epidemiological realities are, earlier we were implementing polio, we were administering different kind of polio polio vaccine to our newborn children. Now we need level 2 polio vaccine for our children. Second thing is new epidemiological reality is AIDS. Earlier this challenge wasn't as much, so now we have to work upon it. AIDS and other things is problem of drugs and AIDS correlation, like this syringes being used by youth in Punjab to take drugs, injectable drugs. So what is happening is that is leading to AIDS in that state. The prevalence rate of AIDS is increasing in Punjab because of this thing. So these realities are to be reflected somewhere in the policy document for the government to take an effective action upon these areas. So that is another thing. Moving to the last point in this slide, that is Global Burden of Disease Index, which is a report on Sustainable Development Goals status of India, shows that India has got 143 rank out of 188 countries in total, which is a shameful thing for a country like India. Why shameful? Because we are behind countries like neighboring countries like Sri Lanka. Sri Lanka has got a rank of 79. Sri Lanka too has a rank of 79, and Syria, which is a war-torn country for the last 5 years, that too is ahead of India in terms of having a rank of 117. Those who are a little enthusiast kind of students, they can have a look at this report in the newspapers of September 2016. Some clipping you can dig out through Google. So September 2016, this report is given somewhere in on the date 4th of September, if I'm not wrong. You can check it out. So that is the reason that we need to have this policy. Even China, if we compare ourselves with China, Sri Lanka, these countries are ahead of us. Even Iraq is ahead of us. So we need to take some serious steps to improve this pathetic situation so as to achieve sustainable development goals this time. So let us move to the next slide now. The question that arises is, there's a big dilemma for India now. What is that dilemma? Let us see in detail. This slide, the discussion on this slide will help you understand the broad contours, the features of this policy in the subsequent slides. So this discussion is going to be... Now see, the thing is, the most visible weakness is the lack of capacity to use higher level of public funding. Now, as we all know, the growth level of India is quite high in terms of what world is achieving. So that way we have got funds, even though we are still short on funds considering the enormity of challenges that we face in terms of our health indices. So enormity of problem is also big, but we are talking about resources in terms of the handling capacity, the handling institutional capacity of the government machinery. So this is the thing we are going to talk about. The thing is, we have for decades now, we have neglected our health sector. We were relying on private sector, or if private sector was unwilling in certain areas to go there, we did not even think of providing the basic minimum health services to those areas. Now what has happened is, due to continuous neglect of this entire continuum of health, we are lacking on every area, be it the infrastructure, the health infrastructure. When we talk about health infrastructure, we have to have public sector undertakings manufacturing cheaper drugs. We don't have that. So, and when we talk about other infrastructure, that is the hospitals. When I say hospitals down to the level of primary health centers, then secondary health centers, then district hospitals. So we are lacking in primary hospitals. And then let us talk about the manpower. There are no doctors in the hospitals. If at all there are hospitals, doctors are not willing to come to public sector hospitals because of the lower salary. Then let us talk about other things. The diagnostic infrastructure. We don't have, X-ray machines at every primary health center. We don't have, other kind of health sector paraphernalia, the machinery, the equipment that is required in the hospitals. So, and we don't have the industry to manufacture this health sector infrastructure, this health sector capital machinery, what we call as X-ray machines, other CT scan machines and other things. If we import that, that is again like relying on private sector or the foreign countries. So this is the challenge we are facing. Now we relied on private sector to provide health services. We remember the names of Fortis Hospital. We talk of the names of various private hospitals which are reputed. But can we name any other public sector hospitals except PGI, except AIMS? These could be counted on fingers. So that is the thing I am pointing towards, that the health sector is so skewed in the in the favor of the private sector that government cannot imagine spending on health without the help of the private sector. So this is, this has got a tilt of the government. The tilt of the government towards relying on private sector is visible. This is, a neglect which is, which is not, good for a country which has had a socialist past. And secondly, health is such a basic service to be relied on private sector, because the motive of the private sector is profit. Now we are in a trap that if we want to change this situation in the short term, we at least have to rely on the private sector. If we want to spend 2.5% of GDP all of a sudden from 1.15%, so we will have no other option except to ensure this spending by private sector only. So this is a dilemma. We cannot build the public sector infrastructure in the short run, because ultimately we need to provide the services immediately to the citizens. So that is the concern. Now the center says in this policy, central government is going to change this in partnership with the states. So let us see how that is going to happen to make the best use of targeted government spending of 2.5% of GDP by 2025. It is not immediately that government is going to do it. So this is a very idealistic line that says, as it is not only about more money for health, but also for more health for money. More health for money, that is, even if we are spending the same money, we want more health out of it. The proportion we are talking about here, that we want to derive the maximum utility per rupee spent on the health sector. That is the objective of this health policy. You need to remember it so as to answer it, your mains questions. So let us move forward. Key features of National Health Policy 2017. See, there are three broad pillars under which I have divided the key features of this policy for the sake of convenience in memorization of these features. Now let us see what these features are. Number one is preventive and promotive healthcare. This policy seeks to provide preventive and promotive healthcare. We will see it in detail what this basically means. And second thing, this broad pillar is universal access to quality healthcare services. Universal access means rich, poor, whosoever that person is, universal access will be provided. So at affordable cost, because we say poor, so the cost has to be affordable. It's not that you are going to charge Fortis like fees from these poor people, disadvantageous sections of our society. So that is going to be the fundamental objectives of this policy. When we say these three pillars, it is on these three pillars, it is under these three pillars, you can say all the other features could be subsumed. So this is 1, 2, 3, 4. We are going to see in the future, in the subsequent slides, that this is going to happen. If you remember these contours, you can fit in the filler points. That is the best way to memorize them for your mains preparation or for answering the MCQs in prelims as well. So this is the way we are going to do it. Let us see what are the key features which we can put under preventive healthcare, preventive and promotive healthcare. So let us move ahead. Yes, the pillar is this is pillar 1, preventive and promotive health. Patient centric and quality driven. So this is patient centric. Were we not patient centric in the previous policies, in 2002 policy, in other previous policies? I think we can answer this in a way that patient centric here means that. So patient centric here basically means that in 2002 policy, it was basically curative in nature. when we say curative, that when the disease has already occurred, it used to cure it. It was centered on curing the disease and not preventing. So this policy is unique in its ideals, that it wants to prevent the diseases in the first place. Then when we say we have to be patient centric, when we have such a lofty objective, patient centric basically means there will be digital citizen. There would be digital citizen health cards, which would have a complete track of as to when the patient visited the hospital, what was the cause of what was the ailment he or she was suffering from. So a complete track of the health record of the patient would be kept. On the basis of this health track record, the treatment would be administered to the patient. So what will happen is, if a patient is suffering from some ailment, after he is to visit the hospital for the same ailment for after a gap of 1 or 2 or 3 months. So this data keeping, the report citizen health card will enable the person who is like the doctor to see if there's any grave problem taking place within the body of that patient. So I mean to say that it will help in tracking as to what the patient is going through. Why does a patient need to come to the same hospital or to the other different hospital, but for the same problem? So this computer based citizen health cards would enable the doctor sitting across various hospitals, wherever he visits, be it in different parts of the same state or different states, to analyze the cause of the drugs administered, the kind of the treatment given to the patient, or the long-term implications of the same ailment he is facing. That will enable the citizen-centric approach in this way. Earlier, what used to happen, if a patient visited different hospitals, different medicines, without taking the long-term picture as to why the patient is suffering from the same medicine at different same problem different times. I would give an example of DOTS strategy to eradicate tuberculosis. So please go through DOTS strategy. This DOTS strategy is based on this thing as only. Now let us see the second point, integration of all schemes. We can very beautifully see this thing being implemented in the sense that when we say integration of all schemes to achieve the health objectives, we can visualize Swachh Bharat Abhiyan. In this Swachh Bharat Abhiyan, what is happening? We are promoting hygienity. Hygienity would lead to lesser morbidity. Lesser morbidity means lesser incidence of a person falling ill. When we say that there would be hygienity in a way leads to lower level of medical problems a person facing throughout his life. So that is the interlinkage. We can see another interlinkage, in fact a more complex one, under maternity benefit scheme. This is a kind of promotive aspect of it. The mother would be looked after by an institutional by some doctor in the institutional setting. So maternity benefit scheme we are talking about, and 6,000 rupees would be given to take care of the hygienity and sanitary needs during her pregnancy. So this in a way leads to integration with another aspect, that is taking care of the newborn baby as well. So this way IMR would come down. So that is the interlinkage between various schemes that this policy seeks to promote. Now let me remind you, we are here at preventive and promotive healthcare. All these points, if you visualize, that these all aim at prevention of the occurrence of disease and promotion of the health. So health and welfare centers are there now. Under this health and wellness center contour, the idea is to have health and wellness centers in the proximity of the citizens. Like every 10 to 15 kilometers area will be catered by health and wellness center. So health and wellness, when we attach the two terms, that means there would be yoga centers in between these wellness centers, these health centers. So these are basically the primary health centers which are going to be redeveloped or recast as both health and wellness centers with new technology, new equipment, and hence better, and also the better manpower in terms of doctor and other staff. So fourth point is shift from selective care to comprehensive care. Let us analyze this as well. Now when we say selective care to comprehensive care, there would be a broad package of health services to be provided to all the citizens in the form of what we call as, a comprehensive package would be given. Periodic tests would be there. This diagnostic tests would be conducted on all the patients, on all the citizen patients, that would ensure that they do not come up with any incipient disease that is taking place in their bodies. So there will be regular tests related to diabetes, related to BP, related to other things. So this kind of comprehensive care is to be given under this policies. How it was selective care? It would ensure better understanding. Selective care, it means whenever you used to visit the hospital, what happens is you tell the ailment, medicine is given, it's okay. Now if you are suffering from cough, what will happen? You would be administered cetirizine and it's okay, it's sufficient. Now comprehensively it will be looked upon in terms of whether if you are suffering from TB or not, the underlying disease would be looked into. So that is the kind of comprehensive care. All the diagnostics, x-rays would be done there and then itself, rather than delaying it to the more next adversarial stage. So this is the idea. This is preemptive care. Again, this DOT strategy, as I talked about, this is preemptive only. And preemptive strategy, we can talk about immunization of children. That would be more aggressive, so as not to let the disease happen in the first place. And that is the idea. In terms of preemptive care, we can also take the example of AIDS, wherein what the NACO is doing, National AIDS Control Organization, it is creating awareness programs so as to spread awareness regarding AIDS. So how AIDS occurs and other things, so that there is preemption. They're not letting the disease occur in the first place itself. That is the idea. Let us move to the next pillar, that is pillar 2, universal health care. So this is a very good objective of this, that it seeks to ensure National Health Rights Act. Now remember, when we are given a Rights Act, don't get misunderstood that this is a fundamental right. As I said at the outset, Article 47 is being implemented partly. That only meant that an assurance is being given that good health, better health facilities, health as a right would be provided. But this is not an entitlement. This is not something against the violation of which you could go to the Supreme Court and plead the violence of your fundamental right to health. This is not the case for now. But yes, looked from a positive angle, yes, it is a good achievement indeed that we are at least moving towards that direction, because if we see in the past, right to education was enacted in this way. First, it was given as a policy measure, and then it was enacted as a fundamental right. Because what happens is, if we enact any policy as a fundamental right in the initial stages itself, then there would be challenges. There would be litigations against the government. So this is the reason that government is implementing it as a fundamental right in a piecemeal approach. So what this policy gives you is the journey towards the fundamental right to health in the, you can say, 5 years, 10 years, 20 years down the line. This basic minimum package of health services, it ensures universal healthcare. All these points would be subsumed into this broad pillar, if you can visualize. So universal, if we are giving basic minimum health package services to all, that is the element of universality. Universality means given to all, one and all, irrespective of age, irrespective of gender, irrespective of level of wealth a person has. He is a rich or poor, that doesn't matter to this policy. So this is the thing. National Health Right Acts also give the basic fundamental health commitments to all the citizens without any distinction. The third point is provision of services even through private sector in the short run at least. So when we are talking of universality, even where the hospitals are not available in the public sector in some areas, we would ensure the provisioning of health services through private sector, taking the help of private sector. Now let us see the pillar 3, which talks about affordable care. What does affordable care means here? Affordable care means free drugs, free diagnostics, and free emergency care services. Free drugs, Jan Aushadhi centers are already working in some states like Rajasthan, Tamil Nadu, where under Jan Aushadhi schemes, free medicines for whatever ailment a citizen is suffering is given to the patients. Like these generic medicines are given under this thing. Now under free diagnostic, we talk about Under health and wellness centers, free diagnostic facilities would be provided, free x-rays, free blood, frequent periodic blood test, and these kind of basic minimum health services would be provided. So that is the thing, in all public hospitals only, not in private hospitals. You need to mind it for your prelims. So the policy talks of raising public health expenditure to 2.5%. How this point caters to affordable care? If the government is spending, then the cost of the out-of-pocket expenditure would definitely come down, and the public health services would be available. Better public health services would be available. That will make it affordable indirectly, you can say. The third point is reduce out-of-pocket expenditure. At present, WHO says that India people have to spend 70% of their health expenditure out of their own pocket. It is just the 30% which the government is spending. So this will reduce out-of-pocket expenditure. When this is increasing, this will reduce. So that is the thing. Now let us see, it says reinforce trust in public healthcare system. Over a period of last 20 years, you can say, what has happened is, when the moment you talk of public, going for treatment in public sector health facility, there's a big no from your family members or from anybody around. They say go to the private, you would be cured in a better way, and other things are given. So there has been a substantial deterioration in the trust, our public's trust towards public health systems. So that is going to be restored under the policy by giving better facilities at public healthcare systems and better provisioning of doctors. Now when we say national health, when we are going to provide the care at the affordable cost, there has to be some standards organization to check the malpractices by private sector. We have talked about private sector in the previous slide, that private sector's help would be sought in the form that we are unable, because we are in the short run unable to provide the services under the public sector umbrella. So private sector, somebody needs to be there to check the prices. Remember, at present we have National Pharmaceutical and Pricing Authority. That pricing authority is regulating the prices of only drugs. So this National Health Standards Organization would be broadly regulating the standards and the prices and the practices in the standard operating procedure, you can say, and the practices across the length and the breadth of the country. So this is the way they are going to ensure the affordable care, so that in one corner of the country, in one village, the health facilities, the health services being provided by a doctor are not being charged for exorbitantly by that doctor. This is the objective of this standards organization, and it will also create a standard operating procedure for every ailment, every major or minor ailment, which would ensure that doctors go by that book rather than going by their own silly logic. Doctors have to ensure that if a person is reported of TB, this and this medicine is to be administered for this and this time. It has to be generic medicine only. Then that reduces the doctor's discretion in a way, and insists upon patients patient-centric care. So that is the idea. Let us move now to other features. These other things are being addressed by the policy are, that is, strategic concerns are being taken care of under this policy. These APIs are being taken care in the sense that we heavily depend upon China nowadays, though we have a very good pharmaceutical industry at our domestic level, but we are dependent on China and Israel for importing these active pharmaceutical ingredients. These are like chemicals, the basic chemicals that are put into medicines to come out with the final medicines. We have the industry to manufacture to process these APIs and come out with the medicine, but we don't have the generic material, that is APIs. From a layman's perspective, APIs are what salt is to any dish we prepare. So APIs are to medicines what salt is to any dish we prepare, in the sense that these are basic ingredients for every drugs. These are different from drug to drug, but these are basic ingredients. Now we are dependent on China. This is a strategic concern, because let us suppose, what if China stops the supply of this today? We would not be able to fend for the medicinal requirement of our population, health requirement of our population, because we won't be able to manufacture the basic drug. the basic medicines that we need. Second thing is pluralistic healthcare system. Pluralistic healthcare system, when it says an integrated continuum of different spheres where all these sectors would be integrated. We are primarily now reliant on allopathy. So there are certain diseases, treatment to which is not still available in the allopathy. The research has not been done, or it has not culminated into some treatment. So for that, yoga is there, all thanks to Baba Ramdev. And other things is Ayush is there, Ayurvedic is there, homeopathy is there. Homeopathy offers many solutions to many health problems which allopathy cannot yet offer. So there's going to be pluralistic healthcare system where excessive reliance on allopathy would be reduced. Why this objective is important? This is important in another light, that multi-drug resistant TB like things are emerging. We are becoming drug resistant, where earlier 2-3 days administering of a particular drug used to cure the ailment, now it takes 7 days. So this way we are becoming immune to the effect of the drugs. So that is the reason we need to depend upon our age-old Indian tested on the Indian soil Ayurveda and other things to take care of our ailments. So that is the idea behind it. Let us see this point, yoga in schools and workplaces. This is the thing that now the children would be made to go through yoga every day, or this thing. This is a part of the promotive feature, the promotive healthcare. And this fourth objective is giving back to society initiative. It has been observed that doctors, after completing their degrees, they do not prefer to go to rural areas. So this is the objective of society, the health policy, to make the doctors go to the rural areas, to cater to rural areas on a voluntary basis. So this is an idealistic objective. Let us see how far it is going to be achieved. Now another authority, National Digital Health Authority, would be created, which would be a repository of data for all types of health ailments that a particular demographic area is going through. Let us say if some area is there, like Kerala is there, Tamil Nadu is there. So these areas, all the health ailments that the population of this respective state has gone through would be available at the click of a mouse. So that is the Digital Health Authority's role, and how many types of medicines are needed in this and that area, that would be forecasted in the real time basis. That is how we are going to go with it, and it is on this basis that prices of essential medicines would be determined, and other health sector the health sector standards would be devised. And other feature of this Digital Health Authority is that periodically we come across NSSO data, some other data is coming which is very fragmented. Sometimes AIMS comes up with a study, sometimes some other hospital and institute is coming up with another study on the demographic patterns of disease distribution. Now this data would be seen in a holistic manner through digital repository of data created by National Digital Health Authority. So this is a good step indeed. Now let us come to the final leg of our discussion, that is criticism. It is different from draft policy 2015. This policy has been carved out of draft policy of 2015. This draft policy differs from the this new policy, the created policy, enacted one, differs from the draft policy. This draft policy was put 2 years ago, that is on that is in 2015 on the health website of the Ministry and Ministry of Health and Family Welfare. Now after discussions and debates with the public, this policy has been reduced to 2017 policy, which falls quite short of what was enunciated under 2015 policy. For example, 2015 policy talked about achieving this spending target of 2.5% of GDP by 2020. Now this policy 2017 delays it to 2025. So that is the thing. First point is, first, to make health a justiciable, fails to make health a justiciable right. How is it? Only assurance, not entitlement. Only assurance means, like it talks about, it assures the citizen that yes, government would provide you certain standards of health, certain health facilities, but citizens are not entitled. When they are not entitled, they cannot go to they cannot challenge even when they are not provided with the services. So that is the idea. Second thing is pushes GDP expenditure target to 2025. We have discussed it already, that earlier it was to be achieved by 2020. Expenditure short of WHO norms of 5% of GDP. In many countries, many well-developed countries, we are not talking about Scandinavian countries, though those are an exception, they spend around 13% of their GDP. The Scandinavian countries spend 13%. We are talking about normal countries which spend 5% of their GDP. WHO says it is quite short of the kind of population India has, and also the kind of disease burden the India bears. 5% of GDP, 20% of its population is suffering from the 5% of GDP to cater to 20% of the global disease burden that India bears on its back. So that is the thing. So fourth point is toothless National Health Standard Organization. We had discussed at the outset in the first slide that health is a state subject. Now this body is being created at state level, national level. So how come a body on a subject mentioned in the state list would be able to ensure the uniform standards across the length and breadth of the country, that is across various states? So this is the idea. It is said that under the policy, State Health Standards Organization 2 would be created, but but when there is no teeth to this organization, it is a toothless organization. How is it going to ensure this? So there are many bodies like National Mental Mental Healthcare Association is there, other bodies are there. How is it going to subsume their functions as well? And then there's Medical Council of India is there, Dental Council of India is there. Various activities, various standards need to be carved out. This Medical Council of India reports to the respective state governments. It caters to the requirements of state governments. So ensuring uniform standards across the length and breadth of the country in a scenario where the mandate is given to the state governments, it is going to be challengeable. It is going to be a challenging task for it. Now fifth point is contracting out to private sector versus affordability. So this is again contentious, controversial point, that at one hand we are contracting out to a sector which is profit oriented under PPP mode. So private sector is profit oriented, public wants good services, and let us say this P is for government, which also wants better delivery of services at a lower cost to citizens. Then it is only the profit wala P that whose objectives are not in sync with the objectives of rest two Ps. Public and the government, they both want better facilities at the cheaper cost, at least in letter. But private sector in letter and spirit both wants profit out of it. So that is the real thing, guys. How the interests of both these contradictory objectives going to be fulfilled? Affordability cannot be ensured where the motive is profit. So mostly we are reliant on private sector. At least in terms of good treatment, it is only the private sector which is existent. A timely service provision, if we consider, if you enroll yourself for a number in the AIMS, then it will take you 2-3 days. So there is no point in relying on private sector. So we have ultimately to depend upon public sector, private sector, which is going to charge fees. So all the citizens, all the poor, disprivileged sections of society cannot pay the fee which the private sector is going to charge. So that is the thing. Sixth point is no special concern for rural areas, only voluntary services. Policy assumes that doctor would be prodded or persuaded to go for a voluntary services in rural areas, and they would go. So that this is quite idealistic in real sense. How many doctors would go, it is to be seen. So this was essentially the criticism and the discussion of the national health policy. I have discussed all the contours, criticism, positive aspects, features, and the bigger debate that we had, like there's no capacity to absorb the funds. So it is in this light that you need to answer any MCQ that comes in prelims having a holistic background. The task for you is to go through, at least for prelims, to go through the National Health Policy 2002, because this policy, the new policy, its details are still under formulation. Nothing is yet out as to how it will be implemented. UPSC is more keen on asking the background things, that is national health policy. They may ask other areas related to health. For example, they can ask national AIDS control program or other things. So this was all, friends. If you like this video, kindly follow with the comments in the section below. Another thing for you, I have created another slide that deals with things to remember for prelims, that is DPSP related to health that we had talked. That is 47 directive principle, article 47, and you need to look for other DPSPs and article 41, article 21 of the constitution, which could be under which the health right to health could also be read, because it is part of the broader article, the fundamental right, that is right to life. So you can read it this way. You have to analyze the things this way. Read other articles under DPSPs which deal with it. Health as a subject is mentioned in the state list. Please remember while answering the MCQs. And for mains, UPSC Mains Exam 2012 put out this question: there is an urgent need for Planning Commission to revise chapter on health in 12th 5-year plan. Those who are enthusiastic, those who are senior players, they can read this health chapter of the 12th 5-year plan, because this is going to be the last year of the last 5-year plan. The 12th 5-year plan is going to end on 31st March 2017. So UPSC might put you a question from various parts of the 5-year plan, the last 5-year plan. This seems to be the probable area, in the sense of the fact that new health policy has been launched. National health policy has come. So this might be a trigger for UPSC to ask question from this area. So thank you guys. This was all in this video section. If you like this video, do post your comments under the video section below the video, and also share any feedback, whatever improvement you want in my subsequent discussions. Any grievance or any question unaddressed, please write it in your comments. Thank you.